Ladies and gentlemen, please welcome Dr. Stephen Greenberg.
Good afternoon, everybody. Thank you for participating today. It is my pleasure to introduce Dr. Renee Manworren, who will present this year's William Shoemaker Honorary Lecture. Dr. Manworren is a Chicago native. Since 2016, she has led the efforts to make Chicago the first child-kind city in the world, meaning that it has been awarded a certificate from Child-Kind International for its approach to pain management in children. She received her Bachelor of Science degree in nursing from Loyola, her master's degree from Rush University, and her PhD from the University of Texas at Arlington. She is a board-certified pediatric clinical nurse specialist and double board certified in pain management. Dr. Manworren is Director of Nursing Research and Professional Practice and provides clinical consultation in acute pain management at the Ann and Robert H. Lurie Children's Hospital in Chicago. She is an Associate Professor of Pediatrics at Northwestern University Feinberg School of Medicine. Her research focuses on the clinical translation of genetics variability in pain sensitivity, analgesic metabolism, and opioid-induced euphoria. Dr. Manworren was the first pediatric specialist elected to the American Pain Society's Board of Directors and has been a member of the Master Faculty for the American Society for Pain Management Nursing since 2005. She is a fellow of the American Academy of Nursing, has served on the acute pain work group that developed the current federal research strategy, and has been an expert reviewer for the 2018 Joint Commission Pain Standards revisions, and is also a member of the Centers for Disease Control and Prevention Opioid Estimates Advisory Committee. Please join me in warmly welcoming Dr. Manworren as she presents the William Shoemaker Honorary Lecture titled, "Did I Start the Opioid Epidemic?"
Good afternoon. So is anybody in pain right now? Raise your hand. So you're in luck today. I don't have a license in California, so I won't be treating you. But the reason I ask is because the very first pain management lecture I went to was by Margot McCafferty. She's a nurse who gave us the definition that pain is whatever the experiencing person says it is, existing whenever the experiencing person says it does. She was so amazing that I actually arrived at the lecture in labor with my third child. And since the contractions were about 20 minutes apart, I told my husband, that at like noon, meet me at the hospital, we'd go up, have the baby, and maybe I could get the end of her lectures. But she is so amazing that the person next to me noticed that when I started to squeeze the chairs about every 10 minutes, and she suggested maybe I should not wait for my husband and go up now. I said, no, I'm sure I've got more time. And in fact, by the time my husband got there, my labor had stopped. Margot was so great at managing my pain from the podium that I didn't have that child for 3 more weeks. Now, I don't think I'm quite as good as Margot. So how many of you are not in pain right now? Wow, okay, so for those of you who couldn't see, more of you. And let me clarify, you're like a 0 on a 0 to 10, right? Because we love those numbers. Why did I ask? Because nowadays, we are trying to change people's perspective. And we're trying to change their perspective that it sounds like we're trying to make everybody feel like that it's okay to be in pain all the time. But you're not, or you're all on drugs, and that's why you're not in pain. When I started my career, we didn't ask about pain. We didn't rate pain. We didn't ask about pain relief. We didn't have the Joint Commission standards. But I remember patients telling me that they had been given acetaminophen. It didn't work. So they took acetaminophen with codeine, and that didn't work any better, and thinking, wow, I wonder if they are drug seeking. I wonder if they have a substance use disorder. And I don't know about you, I didn't learn anything about substance use disorders. Actually, I do know that 97% of US medical schools say that they teach nothing about pain in medical school right now, just came out. So I can't imagine that you learned a lot about substance use if you didn't learn about pain, right? We now know that 20% of our patients either didn't get relief from acetaminophen with codeine or died from it because of their genetic differences. I support pain as the fifth vital sign. Why? To make pain visible and make it so that we treat it, so that we're aware of it. But just like fever and hypertension, you have to put critical thinking into how do you treat it and when do you treat it. I had the privilege of starting the first pediatric nurse-led acute pain management service in 1998. You know what? I haven't switched any of the slides. Sorry, guys. All right. And this is like the collage of the many hairs of Renee up there, okay? And none of them are good, I know. I was contacted by an attending, my very first consult, and I talked to the family, and they said, you know, at home, we were treating her with an opioid, and here they're giving us ibuprofen, and the ibuprofen's not doing it. So I recommended to the attending that we give the kid what they were getting at home. Now, maybe that's how I started the opioid epidemic. Should I have reported those parents for breaking the law? Should I have reported them to Child Protective Services for giving a medication that wasn't prescribed for their child? The attending actually responded to my consult by saying she didn't expect a nurse consult service to even recommend medications. She thought that maybe I could just talk to the child and the family and convince them that she didn't have pain. Wouldn't that be amazing? I'd have my own TV show, right? I would be famous that I could just talk people out of pain. If you have that skill, I don't know why you're not on TV. Maybe you're on YouTube or something. But it didn't make any sense that that was what they thought could be done. And yet, this is the approach many healthcare providers and healthcare systems are doing. They're trying to combat the opioid crisis by saying pain is normal, and we just have to reset people's expectations. Next to me is one of my patients who refused to have surgery unless she got an epidural, okay? You can tell how old she is. You can probably tell some bit about her diagnosis. It was going to be her 12th surgery. And the anesthesiologist called me and said, did you tell them that they could have an epidural for their exploratory thoracotomy and removal of metastasis? And I said, actually, I didn't even know she was having surgery, but what's the problem? She said, well, I wasn't planning on doing that. I was going to just send her to the ICU afterwards, and they could give her some pain medicine and sedation until she was doing better. And you need to come take care of this. So I did. I found one of the other anesthesiologists who had put in an epidural for her other 10 surgeries. And I asked them if they were available, and they said yes, and I got her an epidural. Because it made no sense to this young lady, her parents, why we were going to give a systemic agent for a local problem that she had effectively been managed before with an epidural. I see this in procedures in the ICU all the time. Patients who are having painful procedures, dressing changes, even blood draws and IV starts, that we give them a bolus of their opioid or their IV opioid or their IV sedation, when really what they need is a topical anesthetic. But is it ordered? Are we comfortable doing it? And is that why we don't? So Brett Gerard opened the meeting, and he was actually the CMO when I started the pain service. So if I started the opioid epidemic, it's his fault. He is now responsible for cleaning it up, which is why his hair is a lot grayer than mine. He was very supportive of us as a nurse-led service, and he continued to allow us and ask us for guidance on how to manage critically ill children's pain. The first time expanding prescribing of nurses' prescriptive privileges in Texas came up, I went to him and I said, we need your support, and he was very supportive of the effort. Unfortunately, that's still in Texas, and still in Texas I cannot independently prescribe opioids. Why was he supportive? Now I think back that maybe he was supportive because the pain service had just been off a 6-week hiatus. Why? Well, on December 30th, 1999, and I want you, those of you who are practicing then, think back what was going on December 30th, 1999. I walked into an emergency room with my hand like this. And before I even got to the triage desk, the triage nurse said, "Are you coughing?" And she sounded like she'd been smoking for at least 30 years. And I said, "No," and she said, "Then it's a kidney stone." And I was like, wow. And sure enough, 8 hours later, I was diagnosed with a kidney stone. She didn't get my vital signs, she didn't ask me my pain, she just knew that's what it was, right? So there I have this diagnosis, and the urologist says to me, "It's small, it's at the outlet, it'll pass." And then 24 hours later, he came in and he said, "It hasn't passed, you're septic, we're taking you to the OR, you're gonna be sicker now than when you're sicker then than you are now, and you're gonna go in the ICU and you're gonna be intubated afterwards, and I'll call your husband and tell him that he should come, but he should drive slowly." All I could remember was being worried that I had my pager literally right here, because that's the only place on the gown it fits, and I was on call because of Y2K. And if I was gonna be in the ICU, how could I suck up to those nurses? Because they had got to like me. Because if those ventilators went down, they were gonna have to bag me. And I didn't want them to, if they had to decide who to bag, I really wanted it to be me. So what could I do right then and there to make sure that I was safe? In the ICU, and I've heard, and I'm so thrilled to hear you have survivors of ICUs talk about their experiences. I don't remember having pain. I don't remember having sedation. I remember smelling so bad I couldn't stand myself. And when they finally extubated me and the nurse said, "Is there anything I can do to make you more comfortable?" I said, "Yes, I know you don't want to do this, but I really need a bath. I just can't stand the smell of myself." And thank goodness that they were there to do that. So I brought up where can nurses, advanced practice nurses prescribe and where can't they? And it certainly makes me wonder what advanced practice nurses' role was in the opioid epidemic. 11 of the yellow states that require some level of physician supervision, and the yellow ones require supervision, the green ones, advanced practice nurses are independent, and the red ones, they really have no prescribing privileges for controlled substances. But of those 11 that require supervision, advanced practice nurses, the highest rates of opioid prescribing. And 2 of them is where the top opioid overdose deaths occurred. Now, I have over on the side Alabama and Arkansas because they have the highest rates of prescribing. And hopefully this shows you that on these select states, there doesn't seem to be any correlation with the amount of prescribing and the amount of opioid overdoses that we're having right now. Now, maybe I started the opioid epidemic in Connecticut because I do have full prescriptive privileges in Connecticut, and I have this plaque hanging on my wall. And somebody pointed out to me when they read it that it's really a form letter, and that it maybe is not so much a commendation, but a condemnation for being one of the top 10% of prescribers in the state. I really thought of this as a tribute to what I was able to do, because I was pretty much the only prescriber for kids with pain and palliative care in the state of Connecticut. And shouldn't I then be one of the top prescribers of opioids when those were the patients that I was taking care of? Shouldn't I be somewhat comparable to my adult colleagues? Why do I think we should be providing that level in opioids to children? Well, I started looking at the gap between knowledge and practice back in 1985, and that was me before LASIX. This is me after LASIX. And hopefully you can tell what her diagnosis is. This is my daughter, Brittany, my firstborn, 1985. In case you can't tell because you're way in the back, she has Down syndrome, and like most individuals with Down syndrome, 60% have a heart disease, a congenital heart defect, and she did too. So when she got out of the operating room, we were thrilled. We were told there was a 25% chance she would die on the table. There she was, and she was tied up to all these things in critical care, and since I had 3 years towards my bachelor's degree in nursing, I looked at the pump, and I turned and I said, "What's she getting for pain?" And people looked at their feet and they said, well, nothing. And I said, wait, that's not what we signed up for. Why is she getting nothing for pain? Well, babies don't really feel pain. Okay, she was 11 months old. She'd gotten all her shots. I was a good mom. She got her shots. I knew she felt pain. What was wrong with these intelligent people? Why did they not think that my baby could feel pain? There was at least one person who said, well, you know, she has mental retardation. And I said, yeah, and we're not dealing with that right now. We're dealing with the fact that she had heart surgery, and she needs something for pain. She finally did get something for pain, and that's when I really had a mission for what I was going to do with my career. I was going to explain to really, really smart people like those in this audience when they were doing really, really dumb things, and try to advocate for these kids. I've been studying knowledge and attitude for over 20 years in hundreds of organizations and in several dozen countries. In fact, my tool is now in something like 12 languages. The numbers, though, have really not changed. And now what I've been able to show is that there is actually a significant difference in scores on knowledge between healthcare disciplines. So if we're going to, as an interdisciplinary team, work to manage pain, shouldn't we have a shared understanding? And how do we continue to address this knowledge gap so that we really can have best practices? Some say the answers to the opioid epidemic is to get back to those 1992 prescribing levels. And I just can't help but say, wait, so are we going to go back to treating kids like Brittany without anything for pain? Is that really how we came to have so many opioid overdose deaths? All right, Ohio. Who's from Ohio? So the CDC says you have the best practices. They have said you are the leaders in opioid stewardship and we should all do what you're doing. And I can appreciate the pressure that you are under. However, your opioid overdose death rates are continuing to climb. And while you are only second in the nation, and you were at one time first, they are out of control. And yet, you have reduced opioid prescribing more than anybody else in the country. So I want to warn you about us saying things are best practice until we actually have some evidence that they're best practice. Prescribing rates are now 19% below where they were in 2006, and doses have also decreased over time, with a rate of 58.5 opioid prescriptions for every 100 Americans. Now, I always like to clarify this because it sounds like half of you have an opioid prescription right now. And that's not really what it means. It's really that 17% of Americans in the last, in 2017 got an opioid prescription. But on average, there were 3.4 opioid prescriptions. The average daily MME or morphine mill equivalence was 45. That's greater than 5 milligrams of hydrocodone every 4 hours, but it's less than 10 of hydrocodone, and it's less than 5 of oxycodone every 4 hours. The average number of days has actually increased, and I wonder if this is because we have really attacked and decreased what we're doing on the acute pain management front, but our patients with more chronic pain, cancer pain, now lengthening that time that patients are getting prescriptions. Legislative actions that address this were very late. Prescribers actually started to make the change first. So as was mentioned, I've been able to leverage Brittany's story to advocate for better pain management for kids. And in fact, in returning to Chicago after 25 years of being gone, I pitched the idea of pulling together a partnership of Chicago hospitals to pursue making Chicago the first child-kind city. A city that all children, no matter where they sought care, received care that was sensitive to their pain and received the very best pain management. We have 3 hospitals in Chicago that are now certified: Lurie Children's, Advocate Oak Lawn, and Central DuPage Hospital. Hopefully this year, Rush University will be, and University of Chicago Comer will be. And if anybody else is from Chicago, I need some leaders in some other hospitals. Now, when I took the job at Lurie, I had said to them that I've been telling the story about Brittany to advocate for a long time, since 1985. And that they needed to know I'd continue to tell that story. And then I tell people all the time that that incident happened in a large Midwest hospital, university-affiliated, freestanding children's hospital. Can you guess where it happened? Well, it used to be called Children's Memorial. So I think I probably wouldn't have taken the job unless it was called something else. And now it's Ann and Robert H. Children's Hospital. And I can tell you that we don't treat kids who have cardiac surgery like that anymore. But on my way to Chicago to make this drastic change, something maybe funny, maybe not too funny happened. I actually came very close to being a victim of the opioid epidemic. And I really, seriously, I'd like downloaded the app that I could do like open mic night, although now I'm glad that I got the job because I might have had to sell my house. But what happened was I had accepted the job. I had to give 120 days notice for my previous employer, and I had to have my pre-employment physical within 30 days of starting. So I was pretty sure I could pass that. I filled out my medical history and I said that I took ibuprofen, Maxalt, Ambien, hydrocodone, PRN for osteoarthritis and migraines. And the resident, and all it said on his shirt was ER resident, I don't know his name, he said that because of my position, because of my risk for addiction, I would need to be cleared by their psychologist. But their psychologist had had a baby that morning, and therefore, I would have to come back. So I tried to explain to him that I lived in Texas, I worked in Connecticut, and I was now coming to Chicago. I just got a lease on a condo, and I wasn't planning on flying back till the day I started. And he said, well, let me get my attending. And the attending came back and she said, yeah, so you don't have a job until our psychologist says that you are not an addict and you are not at risk for addiction. And I thought, wow, he must be pretty amazing that we got to wait for him. And what do you mean? I waited 120 days. I got to wait how much longer? The COO of the hospital actually intervened and said they could figure out another way to get me this evaluation. So on the first day when I was supposed to start work, I actually went to this private substance use treatment center, analysis center, and spent 8 days. They normally take a week, but they did it in 8 hours. They put me through a battery of tests that include everything from psychological tests, decision-making tests, donating 3 inches of undyed hair, which was the hardest part. They determined 2 weeks later that I did not have a substance use disorder or a personality disorder, which I was glad to hear. But they recommended that I change my migraine management. Now, I thought this was interesting that they were telling a pediatric pain management specialist how to manage their pain. And they were actually people who treated substance use disorders. That's kind of like me treating substance use disorders instead of treating pain. What did they say? They said they recommended a daily preventative medicine. So the American Headache Society migraine consensus stations in 2015 and 2019 would disagree with them. Based on those, it was not indicated. We had never discussed that when my migraines had been 3 to 5 days per week, I had taken propranolol daily, which had reduced them significantly. And I had continued to take propranolol until I had septic shock, and they recognized that I hadn't had a white count over 2 in over a decade, except when I was septic. They had, at the time they took me off propranolol, I tried topiramate, which is supposed to be great. It's supposed to help with weight loss. I was so jittery, I couldn't sign my name. I was so jittery, I wasn't comfortable driving, and finally my husband said, you gotta get off this stuff because I cannot be driving you to work, and I don't know that you should be making decisions about controlled substances in children if you can't even drive yourself to work. They also had tried to take me off the hydrocodone, which I only used if the Maxalt failed, by giving me butorphanol, which was really good until I started to hallucinate on it. And my husband used to take the kids to the McDonald's playground when I was having a migraine, and I made him take me with him while I was hallucinating. So picture that, you're at the McDonald's playground hallucinating with a migraine. It was awful. They did say that they checked the prescription drug monitoring program in Connecticut, Illinois, and Texas, and that they had found 3 fills for hydrocodone from 3 different doctors in 30 days. And yes, absolutely. My I usually did my annual physical around my birthday, so that had been within that 30-day period, and my PCP had given me 20 of hydrocodone. I then had hand surgery. This finger was straightened. I know you might not think it was straightened, but it's way better than it was. And they gave me 10. And then the week later, I had my gallbladder out. And the gallbladder doc, that surgeon, gave me 10. So yeah, I had 3 fills. But they didn't look to see that I hadn't had a fill other than my birthday one since 2002. They recommended mindfulness to treat acute migraine attacks. My mindfulness when I'm having an acute migraine attack is my head gonna blow up or not? And I have a deal with my husband that he is supposed to sneak in, look, and make sure that my brains are not all over my bed before my children see them, okay? I know that that's irrational, but pretty hard to get to that mindfulness state. I've had migraines for 25 years. They never asked what other than medications I was doing to manage those. I know that staying up is a trigger, and people who know me know that I really like to stay up late. I blame it on the fact that at the time I was working 7 days on, 7 days off, or 14 days on and 7 days off, or 21 days on and 7 days off. And you know, your sleep's kind of a mess when that's happening, and Ambien would help me get it to not be a mess so that I would not have a migraine. I know alcohol's a trigger, and I did explain this to them, that I pretty much only drank alcohol when I got upgraded to first class on the plane. And so they said, you know, how many? And I said 1, sometimes 2. I can't have 3 because then somebody has to carry me off the plane. So yeah, 1 to 2 a week at most, but only if I'm upgraded. And they said, but you fly there and you fly back, so that's really like 4. And I said, oh no, on the way there, I'm going to work. I can't be taking alcohol before I go to work. I don't drink wine unless I'm in Italy because it is a trigger, except in Italy, and some people can explain that. I know massages work when my migraine persists, but they're expensive and they're not available 24 hours a day, 7 days a week. And I might be the only person in the world who has failed yoga. I worked in Connecticut with 2 integrative medicine physicians and a holistic nurse. And when the nurse retired, Nancy, retired, we made a deal that on Tuesday nights, we were gonna all go to yoga. And we went to yoga the first time, we had dinner afterwards, and they all looked at me and they said, you can never come to yoga again. You ruined the chi in the entire room. And I was like, wait a second. And they're like, no, some people should not be alone with their thoughts for as long as you were. And you can meet us for dinner. But you should not do yoga. So I didn't think that was going to work. I did, though, appreciate their concern. This was in the Dallas Morning News recently, because opioid exposure is a risk, and ready access that we have as healthcare providers is an added risk. This was a story about 2 nurses who died of overdoses. They went on break, and they were found dead in the bathrooms with a syringe of fentanyl in their arms. They also report that there was a physician who also had an incident in this hospital, but we have no other details because the physician was resuscitated. So if I can't predict risk and current opioid stewardship efforts are ineffective, what can we do? In 2015, Erin and I made 3 patient-centered recommendations. First, we recommended teaching patients about the opioid epidemic and their role. And I know I've said over and over again, wait, education alone doesn't work, but we've got to start somewhere. What we did know was we were not giving them good information about what to do with their opioids, how to take them, what was the signs that they were in pain and that an opioid was indicated. We recommended monitoring use, and this is a study we did with patients after laparoscopic appendectomy. We monitored their pain and their use on diaries, but we also had electronic pill bottles that every time the bottle was opened, it would record what time it was open. And I would explain to the families that as the mom of 4 kids, if I got up at 2 in the morning, I might remember the next day to write 2 in the morning, but the pill cap would tell me it was really 1:48, and that's why we were using them. What we found was that the pill caps were far correlated with actual pill use or actual amount of pills that were brought back, much better than the diaries. But notice the variability in what we saw. While over 60% of the patients took an opioid on that first day after surgery, we still had some patients who were taking it the 7th, 8th, and 10th day. And this is on a 0 to 5 scale. We had patients who were reporting pain of 4 out of 5 on days 8, 11, and 13. This is a similar study that we did with patients who had NUS procedure and spinal fusions, what I think are the most painful surgeries that we do to children. And we only have results on part of the patients because some of them never brought in their pill bottles. But of 1,154, of actually 661 long-acting oxycodone drugs, about 67% of what we had sent out, only 364 were taken for the reason they were prescribed. 89 pills, or 13%, were unaccounted for on pill count, and 218 pills we handed back to families and said, dispose of these properly. Of oxycodone pills, from 55 healthy teenagers, we have data on 2,230 pills. 49% were used as they were reportedly used as they were supposed to be. 366 pills, or 16%, were unaccounted for, and 759 pills, or 34%, were returned to families for disposal. We recommended teaching families how to dispose of them. Opioids from previous prescriptions for acute pain are the commonly identified source for misused opioids. Greater than 80% of teens say that they use those opioids for pain. Could it be access to care? Could it be that it worked for them after surgery and therefore it must work for my hurt leg, or it must work for whatever else is ailing me? But there are 35% who have said that to get high was really the reason that they misused their opioids. And they get them from their friends, families, and medicine cabinets. So where do you store your medications? This is a campaign that's been going on for a long time, and it says, put your medicines up, and it says, can you pick up where the medicine is before the 2-year-old can? And hopefully you can. It's right there. Here's the problem. Where do people put their medicines? They put it in their medicine cabinet, they put it over their refrigerator, which is up high. But what if the people we're trying to keep them away from are 15 to 19 years of age? And this is my family, and you'll notice Brittany is shorter than me, and at that time, Jordan was shorter than me, but now Jordan is 9 inches taller than me. So the only person who can't get things off the refrigerator is me. So that's not really a good place to store them to get them away from the 15 to 19-year-olds. All right, my kids love when I talk to them. That's why I don't invite them to my presentations. I became more interested in disposal when Max went off to college. He was too busy the summer before he went off to get his wisdom teeth removed. He therefore decided he should do it the second semester of college. And he called me and he said, Mom, I only used 2. They gave me 20. I got 18. And the guys in the dorm say that I can sell them for $10 a piece. $180. Think back to when you were a freshman in college, away from your mother, who went, oh my God, you cannot sell them. It's illegal, you can't sell them. Send them to me. Oh crap, you can't send them to me, that's illegal too. How do you tell this kid who doesn't have a car to get rid of them? So what do you think I told him? This, by the way, is his beautiful wife that is gonna be in charge of keeping him in line for the rest of his life. So what do? I told him to flush it down the toilet. And when I tell people that, they go, oh no, what about the fish? Okay, I'm worried about the fish too, but I'm really worried about the kid. And the #1 cause of opioid overdose in kids less than 14 is accidental ingestion. So get rid of it. You can go to take-back days. There's this weird thing about take-back days. To remember it, they're always in April, right around tax time. And they're always in October, right around Halloween. So trick or treat, give me your drugs, okay? But are you gonna hold on to them for that 6 months, or what are you gonna do with them? If it is lethal for somebody who enters your home, flush it down the toilet. When you take it by mouth, where does it go? Right. Some people are going, I don't know, where does it go? I hope it goes down the toilet, right? The FDA, the EPA, they're concerned, I'm concerned about the environment, but I'm also concerned about our kids' lives. And there's been no indication of environmental effects from flushing. For those of you who don't know, where do nurses give the partial doses? What do they do with what's left? They put it down the drain. And so if you're worried about water, don't drink where you work, okay? I also investigated a complaint for IV push morphine. A patient had said that the nurses give it in different ways. Some give it right at the hub, some give it fast, some give it on the pump. And we wondered why were they doing it? And we found that nurses were acting on non-evidence-based ideas of how to prevent substance use disorder after legitimate exposure to opioids. And you can see right there, they didn't want the patients to get addicted. They thought by how fast they pushed it would have something to do with it. And it might. In retrospective case-controlled studies, individuals with opioid use disorder recall greater opioid-induced euphoria with initial opioid exposure than those who do not have substance use disorders. Valid opioid-induced assessment tools actually exist. They were developed in the 60s, and they're used as part of drug abuse liability testing before approval by the FDA. But we don't assess opioid-induced euphoria in clinical practice, or should we? I'll let you know, I have an R01 at scientific review right now, and if opioid-induced euphoria becomes the 6th vital sign, you absolutely can blame me. Morphine IV push is given safely over 3 to 5 minutes. We changed our pumps from 4 to 40 minutes to 3 to 10 minutes for administration. There's no evidence to support the gender bias that you saw. There's no evidence to support that rush junkies like my son Jack is more likely to develop a substance use disorder. Now, this is a picture of Jack. Jack was ranked in North Texas in motocross the day before I defended my dissertation. And just like there's always these bad wedding stories and there's bad dissertation stories, well, I'm sitting at the kitchen table and I get a call. And I apologize to anybody with a real Southern accent, but I have to throw in the accent, okay? And the call went like this. I called, Miss Manworren, yes? Miss Manworren, I have your son here, and we're at the motocross, and ma'am, well, I don't know how to tell you this, ma'am. Oh, your husband's here too, but he told us to call you, and ma'am, well, ma'am, your son has the biggest set of balls I've ever seen in my life. Thank you. I mean, what do you say to that, right? My husband's there? Yeah. So we asked your husband, we can take him down the road a pitch to the hospital, but we don't know if there's going to be a surgeon, and we're not really sure what happened. All we know is that your son was bringing his bike towards us, and some people had to help him, and ma'am, he looks really bad. And, we could fly him to a trauma center, because you paid the $25 insurance for the free flight to the trauma center, or we could take him down the road. Which would you like to do? And I said, well, what do you want to do? And he said, I'd like to fly him to John Peter Smith, where I am an EMT. And I said, well, if you could get to Dallas, that would be better. That would be closer to my house. But you do what you need to do. Just call me. Let me know where you went. So they called me that they went to Waco. And so I started to drive to Waco. And on the way, I got a call from the urologist. And he said that, yes, they now knew what was going on. What they had to do was they made an incision thinking it was a testicular torsion, and it's not, because what they found was dead bowel. And so they were going to make another incision, and they were going to run the bowel, they were going to clean it out, take out the dead bowel, and I should just drive slowly because it was going to take a long time. Now, I always like to show you where the incision is, because he has now blessed us with a grandchild. And I think it's because there was an arrow pointing to his penis, and that girls started to follow that. So please, if you are a surgeon, do not ever make an arrow towards that on a teenage boy. This case definitely illustrates some of our pain assessment and management gaps. The EMT, the surgeons, figured out what his pain was, even though they told me that he never really told them what happened. He actually told us the next day that he was taking one of these jumps and he hit hard and he got kind of sick to his stomach and he stopped the bike and he threw up, and then he got back on and he rode some more, and then it got even worse. And so he got off the bike, he threw up, and by the time he got close to the medical tent, he could barely carry his bike. He did not know until they showed him pictures of how big his balls were, and he's just as proud as we are that he has such big balls. Post-operatively, now you have the mother who cannot defend her dissertation the next day, and who's a pain management specialist in the adult ICU. And he was hypertensive, but bradycardic, and surprisingly, he would deny pain, and he had a PCA, and I would say, "Are you in pain?" And he'd say, "No," and I'd say, "Then get up and walk." Well, can people walk in your ICUs? Because there wasn't a whole lot of place to walk. And they really had a little ICU, and you couldn't even walk around, and they wouldn't let him go out with the controlled substance, because that was not their expectation. They weren't expecting somebody to have 13 inches of bowel removed, and that night their mother tell them they had to walk, and then say they didn't have pain. They didn't have pain. Throughout his hospitalization, he used exactly 10 milligrams of morphine. Why? Because I know the key to the pump, guys. So I could look it up and monitor him. Physiological measures such as heart rate, respiratory rate, blood pressure are included in our multidimensional behavioral pain assessment tools. But in studies of pain, vital signs do not correlate with brain-based evidence of pain. Vital signs are not specific or sensitive. So why do we continue to use vital signs to say they're in pain, they're not in pain, because it really means nothing? There's greater than 60 observational pain scales out there, and most of them have a facial expression, a body activity, a cry, and verbalization as categories. In brain-based studies, reflexive withdrawal is most associated with brain evidence of pain. And you rarely get reflexive withdrawal except for needle procedures or those type of exam procedures. And those are often things that you should be able to prevent their pain. Of the behaviors included in observational studies, we also have facial expressions. However, the facial expressions described in those are not the same as the facial action codings that we actually see on people's faces when they have pain. It's okay to try to treat opioids and strive for optimal pain relief. No, you are not going to get 0 on everybody. I cannot get 0 on the patients with spinal fusion. I cannot get 0 on the patients with NUS procedures. I can get 0 on tonsillectomies, and I can get 0 on appendectomies. And it concerns me when we say, well, they had surgery, they're going to have to be in pain. Because I wonder what exactly are we using, and can we really optimize those non-opioids to get them to be more comfortable? Communication. The pain assessment tools were meant to be a communication tool. And I always like to point out that the FACES scale only have 6 choices. So where we got to this 0 to 10, nobody should have 11 choices. Nobody. I'm sure if you rate this program, you don't get 11 choices. It's way too many. And I love when the patients say, I'm a 9.5. Well, that is not an option. I already gave you 11, right? And why is it important? When your patients are trying to communicate their pain, they're not just communicating with the number. They're trying to figure out what's the right number. And I'll give you an example. I shared with you I had my gallbladder out. I was working on a grant with 2 of my very favorite basic scientists who happened to be married, who happened to have just had a baby. And I was staying at their house. They had gone to bed, and I started to have this horrible chest pain. And you know how you see it on TV that women's heart attack pain is different? And I thought, oh my gosh, am I having a heart attack? What is this about? And I took some ibuprofen because I had that, and an hour later, I was still like rolling on the floor. I could barely talk. So I texted my husband, who was 1,402 miles away, and I said, I think I'm having a heart attack in Kyle and Aaron's living room, and I don't want their 6-year-old daughter to find me dead tomorrow. He called me up and he said, maybe you should tell Aaron and Kyle. And I said, oh no, I don't want to wake them. Next thing I know, they come tromping down the stairs and they're like, why is John Manworren telling us that his wife might be having a heart attack? Oh my God, Renee, what is wrong with you? And I said, I think I might be having a heart attack. And do you want to go to the hospital? Yeah, maybe. Do you want us to call an ambulance? Heck no, I wouldn't want that. I was going to wait and see if I just died. So they took me to the hospital, and they couldn't find anything wrong. My vital signs were stable. They did an ultrasound. They finally gave me 2 milligrams of morphine, and they redid the ultrasound. And guess what? I had 12 gallstones. It wasn't until they got me comfortable enough that I would stop splinting that they could actually see those gallstones. They then tried to hang fluids and tell me they were keeping me and they'd do the surgery right away, and I said, oh no, I'm on service. I gotta go prescribe opioids to kids at the Little People Hospital next door. I gotta go. And they were like, are you competent? And I'm like, a lot more competent than I was laying and rolling around on their floor. And I had the surgery done electively. I also want to point out, I fly a lot to Washington, and I actually had a congressman, I'm not going to say from where, who admitted to me that he thought the FACES scales caused the opioid epidemic. I don't know how, but please talk to your legislators, because I think they're clueless about what's really going on out there and the pressures that you're under. I want to clarify that asking about pain doesn't cause pain. I want you to believe your patient, but that doesn't mean you have to listen to them when they tell you how to treat them. You need to use all of your medical knowledge, all of your interprofessional skills, and why did what they worked for them before, or why have they not found something that works? We use a lot of euphemisms for pain, and one of my favorite is poke. And I put on here the "you don't grow out of pain." My daughter has been blessed that she has had a topical anesthetic for every single immunization and blood draw until we went to, and I always forget the name, but you'll know what it is, until we went to get the immunization so that if you have sex, you don't get cancer. And I took her there, and I thought she was old enough, and I didn't give her a topical anesthetic, and she had a meltdown. And I literally, the pediatrician said, you know, legally you don't have to give it. And I said, that's fine. The two of you signed somewhere that you promise she will never have sex ever again. Or ever, ever. Write that down. And he said, oh, I think you're overreacting. So we put a topical anesthetic. My husband brought her back, and it went much better. Stop recommending things that there are absolutely no evidence that they work. The Olympic Organizing Committee did an evidence review. The American Pain Society did an evidence review, and on both of them found that there's no evidence that ice decreases swelling or decreases pain. Are you shocked? I certainly was. And yet, the Olympic Committee still recommended ice. And when I asked them in a public forum why, they said, because you can't spell rice without it. And that without effective non-drug, non-doping treatments, they chose to recommend ice versus other things that might be more harmful. Let's partner with our patients. What works for them? I have no doubt that ice works for some people, but let's not tell them this works and this is what your treatment plan is if it doesn't work. The brain is powerful. And I'm going to end with this one. And this is my husband, because I didn't get to talk to him about him. Jordan is my youngest, my 5'9". She taught me brain is powerful. I told you I flunked yoga, but Jordan was born on the bathroom floor. And I don't have any opioids at my home. I don't have a local anesthetic. I had actually begged on Labor Day for them to put my epidural in and just wait the 19 days till she was due. And nobody would do it for me. I don't know. They're kind of wimpy. But what ended up happening was my husband was out of town, and I was in labor. And so if you live in Texas, I learned you go and have Mexican, that will speed up your labor. I watched 2 movies. I sent my kids to bed, and there we were. I called my husband and I said, I'm having contractions about every 5 minutes. I'm supposed to call the hospital. I'll call you. I think I got about 3 hours. And then I said, honey, I got to get off the phone because I really have to go to the bathroom. And this is where most healthcare professionals go, what were you thinking? And I went to the bathroom, and next thing I knew, there was a head. And I was alone in my bathroom telling my husband to drive slowly, that he had 3 hours. I managed to do it without screaming, crying, anything, because I woke up my then 11-year-old son, and I didn't want him to be damaged forever. And I said to him, I need you to call the neighbor, Mary, and I need you to have her come over. Mary wasn't home. Her husband at 1 o'clock in the morning answered and told my 11-year-old that Mary was working and that I should call back in the morning, and hung up on him. So I then called the next neighbor, and I said, tell Jackie I am having the baby in the bathroom unless she gets here right now. And he said that, and then I thought, Jackie is gonna put on her makeup and her jewelry, and she's gonna do her hair, and she's gonna have a matching outfit, and oh my gosh, I'm gonna be here forever. So I told him to call 911. Now, how many of you had pals? When he called 911, I said, tell them I am having a single delivery, I am full term, and I am crowning. And he obediently said that. And he said, Mom, they need to know how old you are. And I said, tell them old enough to have an 11-year-old on the phone telling them that I am full term, crowning, and in my bathroom alone. He said that and he said, Mom, she really needs to know how old you are. It's like, oh my gosh. I then listened to them, ask him my phone number, ask him my address. What the heck do I pay taxes for? Send somebody to help me. Jackie arrived first. She went through the doggy door because she is a good friend to get in. She came into the bathroom. I'll never forget. She went like this and she goes, what are we doing? And I said, Jackie, I have the head in my hands. And she said, do we want to get off the toilet? And I said, Jackie, I have the head in my hands. And she said, okay, put your arms around me. And I said, Jackie, I have the head in my hands. And she said, oh my God, let me help you. And Jordan was born on the bathroom floor. Thank you very much. Let me give you something to do. Your instructions are, when you get home, dispose of any unused medications and tell your friends, your relatives, go to people's house, look in their medicine cabinet. That's how you really know what kind of friends you have. And take them out, dispose of their opioids. And help Brett know what you need to make to better manage pain and your ideas for the opioid epidemic. They have a task force report on the gaps and the knowledge. They have 67 gaps recognized and over 150 recommendations. Tell them if it's any good. Tell them that you're here to help. Tell them that you are going to mobilize our healthcare workforce to get us past this opioid epidemic. Thank you.